Imagine a foundation fracturing under the weight of a building. You can slap a coat of paint over the cracks to hide the damage, or you can excavate and rebuild the structure from the ground up. In homeopathic medicine, the physician's single purpose is the latter. According to Hahnemannian principles, true curing means the gentle, sustained restoration of a patient's overall vital balance. But a major trap awaits clinical trainees. It is dangerously easy to mistake the temporary quieting of an isolated symptom for a genuine cure, while the underlying disease continues to progress. This chart illustrates the difference. In a state of apparent improvement, you might see a brief dip in a specific symptom, like a headache temporarily fading, but the patient's overall trajectory of health continues to decline. The vital function remains impaired. Watch what happens in a meaningful cure. The symptom line smooths out permanently, and the overall health trend line sweeps decisively upward. Vital function and quality of life improve, and no serious condition is overlooked or masked. Differentiating between temporary symptom suppression and true structural healing is the absolute prerequisite for safe, effective clinical practice. This standard of practice is codified in Aphorism 71 of Samuel Hahnemann's Organon of Medicine. This text establishes the structural foundation for all clinical reasoning. This diagram outlines the three indispensable domains of knowledge established in Aphorism 71. Domain 1 is knowledge of disease. Here, the practitioner identifies what must be cured in the individual, looking past the diagnostic label to the patient's unique expression. The second is knowledge of medicines. This requires understanding the specific curative effects each remedy produces. The third is judicious application, governing how the suitable medicine is prepared, dosed, and monitored. Clinical success depends on the simultaneous integration of all three domains. Removing any one of these killers leaves the practitioner to rely on guesswork rather than systematic evidence. To successfully execute that first domain, knowledge of disease, you must act as an unprejudiced observer. This means recording observed clinical facts and strictly separating them from theoretical assumptions. Consider a common clinical scenario. A patient requests a remedy for a recurrent throbbing headache, mentioning that it feels worse from sunlight. Hearing this, an inexperienced practitioner might immediately prescribe a remedy based solely on that single isolated keynote symptom. This premature prescription directly breaches the first domain. The practitioner failed to gather the full chronological history or check for immediate safety red flags. By jumping to a conclusion, they also skipped domain 2, performing no actual remedy differentiation, and failed domain 3 by prescribing without assessing the totality of the case or potential obstacles to cure. Collecting raw information is not the same as constructing clinical knowledge. You have to structure that data to identify which symptoms are actually reliable, relevant, and characteristic. A common amateur assumption is that the difference between an acute and chronic disease relies entirely on how long a complaint has lasted. Duration alone is insufficient. Hahnemann's classification requires a four-dimensional matrix: onset, duration, cause, and course. An acute disease maps here: rapid onset, limited course, linked to a specific cause. But watch the chronic disease profile. Developing gradually, it features a persistent course and maintaining causes, requiring longitudinal assessment. This matrix clarifies a critical clinical distinction. A brand new acute disease is entirely different from an acute exacerbation, which is just a sudden flare-up of an established chronic baseline. If you rely on a single dimension like duration, you will misclassify the disease. And misclassifying the disease guarantees that your prescribed treatment plan will fail. Once you correctly classify a disease as acute, you have to contextualize it by its distribution across a population. If only several cases appear in a specific locality, it is a sporadic acute disease. This usually points to a shared environmental or occasional influence, like weather or local water. If many cases in a population present with a recognizable, common disease process, it is an epidemic acute disease. This demands a much broader public health perspective. This map visualizes how we approach outbreaks using the genus Epidemicus. By analyzing multiple cases, practitioners synthesize a collective symptom picture. Notice how common diagnostic symptoms like fever are filtered out, while unusual characteristics like thirstlessness combine to form a bright archetype profile. To find this collective totality, you must rigorously separate high-frequency, expected diagnostic symptoms from the repeated, unusual characteristics that actually differentiate the illness. Individual characteristics dictate how you prescribe for a single patient, but constructing the genus epidemicus allows practitioners to anticipate and safely manage disease patterns at the population level. Returning to chronicity, we must correct another misconception. An acute illness that simply drags on for a long time has not automatically become a true chronic disease. A true chronic disease requires an underlying, persistent pathological tendency. It is not merely a delayed recovery from an acute event or a complication. Often, the condition persists because of maintaining causes. These are behavioral, environmental, or social factors, like extreme occupational stress, that act as physical obstacles to cure. There is also the artificial chronic disease. To identify this, you must take a full history of prescriptions, supplements, and substances to evaluate toxic loads or adverse effects. We must differentiate all of these established disease states from an indisposition. Described in Aphorism 150, this is a minor, transient disturbance that often resolves entirely just by correcting a situational cause. If a practitioner fails to untangle these layers and remove lifestyle obstacles, even the most philosophically perfect remedy will fail to restore health. We can apply this entire framework to a mixed presentation, a patient with chronic asthma who develops a sudden fever and cough. To complicate matters, this patient is also suffering from severe sleep deprivation due to extreme demands at work. This 3D model isolates the foundational layer. A deep purple glow indicates chronic asthma. Next, blue static over the brain maps the behavioral maintaining cause of sleep deprivation. Finally, an orange flare in the throat shows a new acute infection superimposed on the chronic state. Conceptually separating these overlapping processes transforms a chaotic, overwhelming patient presentation into a highly structured, actionable clinical map. But having a map is only part of the job. The absolute rule of clinical prioritization is that biomedical risk and time-sensitive red flags always override philosophical case analysis. In this mixed case, the red flag is clear. The patient is experiencing rapidly worsening breathlessness. The practitioner must step out of theoretical evaluation to assess the severity of breathlessness, stabilize the patient, or refer them for urgent conventional medical care. Hahnemannian classification remains a dynamic clinical hypothesis, one that must adapt the moment new evidence emerges.